So today we're interviewing Ryan Van Wyck, and he's in Minnesota, just freshly back from Santa Barbara. So
Yes.
welcome, Ryan.
Thank you.
Yeah. So can you tell us exactly where you are in Minnesota and where you work and what your work is?
Sure. So I live and work in Minneapolis, Minnesota. I'm currently at North Memorial Hospital, which is a hospital system in the Twin Cities, and I help lead a PTSD outpatient program in our mental health and addiction clinic, and I also work part-time in the Army National Guard as a behavioral health officer, and also founded an organization called Minnesota Trauma Project that was really developed to increase the awareness and training available to clinicians, particularly mental health providers, around trauma and the ways in which it shows up with addiction and eating disorders, and a vast array of other mental health issues. So.
Okay, thank you. So we ask our speakers to come up with a quote that guides you or that particularly impressed you. So do you have a quote like that?
I do, yeah. I had two come to mind, so if it's okay, maybe I'll share both. But the first one feels like it was something I actually learned while working in the treatment setting from another clinician. And the short version is, the world breaks everyone, and afterward many are strong in the broken places. And so it's a quote by Ernest Hemingway out of the book Farewell to Arms. And so for me, I think when I first heard it, it really felt deeply impactful, just thinking about the lives of the clients who I was working with, and the tremendous amount of strength and resilience that was evident in so many of them who had come out of trauma, who oftentimes had significant childhood and adult trauma. And as a result, were struggling with persistent addiction, alcoholism, and struggling to get their lives back from sort of the persistent pattern of use and relapse and treatment. Oftentimes, for many of them, they had multiple treatments. And so that was sort of the early origins of it. And I think where it's really sort of evolved for me is thinking about the ways in which we all, including the providers, including anybody who's in the line of trying to help people, nobody comes through the world unscathed. We all experience some sense of wounding, either relationally or traumatically in other forms, and identifying and working through and working to heal those places of woundedness within us is oftentimes vital to doing this work well and staying in this work. I think, especially when I think about vicarious trauma and the ways in which when you work with clients who have really difficult histories, we're affected by it. And so, and it stirs up our own. And if we don't pay attention to what's going on within us and deal with our own stuff, it frequently both gets in the way of us doing the best work that we could with people, and frequently will lead to us struggling sort of to maintain that work across time. So,
for sure. And you said you had a second quote?
Yeah, the second quote is from Irving Yalom, who's a writer of many psychological texts, including textbooks on group psychotherapy. But in one of his books, Love's Executioner, he starts off one of the chapters with the unexamined life is not worth living. And it feels like that sort of dovetails into the other quote in a way, because it's sort of the sense that the most fulfilling lives will be the ones where we examine that which is meaningful to us, that which brings sort of purpose and joy and satisfaction and connection. And frequently it's sort of those hidden issues that we're not wanting to pay attention to that get in the way of all those things. And so, yeah, so that too feels like it both guides my own sort of personal work and development, as well as the way in which I try to show up in my work with clients and trying to help them really dig into what's going on within their lives and what's gotten to them to where they are, and how do they move forward from a place of intentionality.
So what brought you into this? How long have you been in this work, and what brought you?
So it's funny. I feel like, so I've been in the field of addiction for the last 9 years, and I would say I largely fell into it. I was finishing my doctoral studies and looking for internships, and the way the internship world works is we apply to a bunch of places and they rank us and we rank them. And I applied to an array of places, including a substance use disorder treatment program, and didn't really have any particular interest in being in that field. But thought I would match it because it was back in Minnesota where I wanted to end up. And so I ranked it higher, ended up matching there, and was really pleasantly surprised by how much I fell in love with the work. Like I feel like I left 4 years of grad school thinking, I don't even know if I want to be a psychologist. And by the end of an internship year, I thought, how would I ever not do this work? It just felt like a perfect sort of falling into place of sort of my own personal path and working with clients whose lives were ensnared with addiction, but were courageously trying to take steps to change their lives and reclaim aspects of their lives that have been lost in the process. And also encountered trauma there, I think, for the first real coherent time, a real coherent point in my professional development. And I always feel like there's a way in which seeing clearly the suffering of other people, it sort of feels like it pulls this response of like, how can you not want to do something about this? And I feel like I've experienced that and encountered that in a more significant way in that setting that I had all throughout my grad school studies. And I was definitely sort of fell into the calling, I think, of it, of really trying to be in that space and help people recover their lives.
And so what is your approach, and how did it start out, and what's the evolution of what you do?
Sure. So I mean, I think like many people, our shifts in our approach are formed by the points of frustration that we experience and the places where we encounter difficulties and think, gosh, there has to be a different way to do this work, or sort of help people change or heal or recover in these ways. And so I think it was interesting when I first started my internship, people would talk about the fact that 75% or so, I was primarily working on women's primary units initially. And they say 75% or so of the patients coming in will have a significant history of trauma. And then I watched as we really sort of a co-occurring disorders treatment setting that was primarily 12-step based. And I think there's a lot of incredible aspects to 12-step community and the ways in which that can really facilitate change for people. And there's a lot of ways in which that setting neglected to pay attention to and adequately address the trauma that people walked into the room with. And so I would say my shift, the shift in my approach has really become one of really taking more of a trauma focused approach to addiction. And I would say it has to also, for me, it has to also be woven in with attachment. And so I really love the field of interpersonal neurobiology, which is a field that developed primarily out of a group of clinicians in Southern California who have now sort of spread across the country and world, looking at how the brain develops in the context of relationships and how sort of inadequate relationships, particularly early on in our lives, give rise to all sorts of different struggles and difficulties. And so I would say I take a very trauma-focused and attachment-informed approach to working with addiction, and really trying to sort of weave those sort of threads into the process of helping people sort of begin to identify those early difficulties and begin to make changes to their lives. So.
And so what are your your treatment methods. What do you use to treat trauma?
Sure. So I've done training in EMDR, eye movement desensitization and reprocessing, um, brain spotting, which sort of evolved out of EMDR, and then sensory motor psychotherapy, which is a body-centered approach to working with trauma and sort of developmental or attachment wounds. And I think, so Judith Herman, who's probably one of the preeminent writers in the field of trauma, wrote a book back in 1992 on trauma called Trauma and Recovery. And so she sort of really, for the first time, made a coherent model for working with trauma triphasically. So really sort of the first phase of work with within that model of working with trauma is stabilization. And so I think similar to the ways in which we think about addiction recovery, you help the people that need it to detox, and then you begin to do the work of reclaiming their lives. And so I think stabilization is in some ways like detox. It's helping people to sort of begin to establish a new baseline. And I think within that triphasic model, phase one is really oftentimes about sort of helping people create new boundaries for themselves in their lives, developing skills and strategies for both regulating themselves, but also receiving sort of regulation from others. And so I think about the clients who I've worked with who have significant fear of relationships and people, and they're thrust into a 12-step community in which they're told to open up and share. And yet the prospect of being close to people is terrifying. And so I think of that phase one work is oftentimes a lot about helping people to begin to sort of increase their capacity for being with people as well as being with themselves. And sort of out of that interpersonal neurobiology field, they'll talk a lot about the window of tolerance, which is sort of this zone within which our nervous system is regulated enough that we can be present to ourselves and present to other people. And so a lot of that first phase of trauma work is helping people to begin to more effectively modulate their nervous system and stay within that window. So the goal is to begin to expand that window of tolerance. And I think for a lot of my clients, their rapid return back to substance use is because there's a sort of very narrow window of experience that they can be present to. And so as soon as they begin to get to the edges of that, their system, their brain says, we know what to do here. Go back to grabbing that substance that's going to regulate your system back down into the window. And so they go back to their substance, and it regulates them back into a state of greater degree of calm. But obviously in that case, they're less present to themselves than to other people as well. So it's sort of a dissociated calm. But they're often sort of regulating in and out of that window of tolerance using substances. And so I think of that triphasic work. A big part of that is working through allowing people to be more present to their world and to themselves. And as you begin to establish a greater capacity for presence to self and others and experience, then eventually you can begin to do some of the greater work of processing through the trauma, which is typically some form of exposure work, which is sort of helping people to go back to the things that they've previously avoided, like the thoughts, the memories, body sensations at times, and be at a different sort of place of being resourced so they can integrate those experiences and thoughts and feelings and sensations differently.
So I have a question, if we can back up a tiny bit.
Absolutely.
So that exposure therapy is probably EMDR and some of the other things that you mentioned. I'm wondering, what are the methods you use to increase the client's ability to self-regulate?
Sure. So certainly I would say it starts with mindfulness. And we know that mindfulness is sort of a gateway to both regulating the sort of the parts of the brain that become hyperactivated. So there's a part of the brain right behind the eyes called the orbital prefrontal cortex that's primarily responsible for observing our own experience. And when it's effectively engaged, it's also directly can influence the amygdala, so it can actually provide a sense of calming to the brain and then therefore to the body. And so mindfulness is oftentimes a part of it, but even there, I would say frequently with clients who I work with, we have to start with developing a capacity for mindfulness as well. So most clients, there's a trauma therapist named Kathy Steele who talks about what she calls the phobia of internal experience as sort of a normative experience for clients who have trauma. And so they begin to become terrified of their own internal world, and so they avoid it. And it becomes a really normal way of going about life. And when that internal world sort of infuses back into their conscious awareness, they do whatever they can to suppress it again. And so I think that's a big part of where substances come into play, because it helps to suppress our awareness of our internal world. And so I think a lot of the process of beginning to increase that capacity for self-regulation or self-soothing is, first, it starts with helping people to identify sort of their own experience of that window of tolerance. And the window of tolerance is sort of, again, it's that space within which the nervous system is calm enough to allow us to be present to ourselves and to others. And then on either side, you can have hyperactivation of the nervous system or hypoactivation of the nervous system. And so it's helping people to begin to recognize that window, when they push out of it, what their triggers are, and then developing specific strategies for either down-regulating the nervous system or up-regulating the nervous system. And so obviously, like there's a term grounding, which is a form of frequently it's a form of down-regulating, but I think it can oftentimes be used bidirectionally. So it can both up-regulate if you do it in particular ways to help you sort of more engaged in the present moment experience, or more often not as a down-regulating process. But I think a lot of the down-regulating strategies are, so some of it can be sensory-driven, so using your senses to re-engage your environment. And one of the things that we know is that our sense of taste. So if you put a piece of gum or a mint into your mouth, and it activates the salivary glands, it automatically sends a signal down to the body that it's calm, that it's safe. And so it's fairly minute. I mean, it won't have a long lasting effect, but it has sort of in the moment effects of helping your system sort of begin the initial stage of calming back down. And when you begin to pair things together in that process of down regulating, like things like extending your out breath is a really powerful way to, and this is sort of an ancient practice, obviously from long sort of Eastern traditions have long held sort of breath as being a primary way to get in touch with the self and present moment experience. But extending the out breath is a really significant one. Finding ways to use things like temperature as a way to sort of calm the body, like the initial shock of cold water on our face, or cold temperature to the back of our neck, sort of right below our brainstem, can be a way to sort of calm us back down. And then finding other ways to calm our system, like we know that like with pets, sometimes we'll use things like thunder vests, where it puts a small amount of pressure on their abdomen or our torso. And people will do that with blankets, and that can be a way to help to sort of begin to help bring about a greater sense of containment, which can help calm the system back down. So I'd say those are all sort of down-regulating strategies. I think up-regulating strategies frequently involve some form of movement. And so I have clients who, while we're meeting, they begin to sort of go into a shutdown state, or sort of more of a hypo-arousal state. And so we'll play catch for most of our session. And the process of sort of engaging another person while doing something that's slightly physical helps them to maintain enough activation in the nervous system to stay present and engaged. And I think for people who get really shut down, oftentimes you're starting with really small amounts of movement and then gradually increasing blood flow, heart rates. So getting people up and walking can be a form of regulation. And and helping them to sort of begin to increase activity both through blood flow and things like that as a way of coming back up out of that hypoactivated state.
So it sounds like when they're hyperactivated, it's fight or flight, and when they're hypoactivated, it's freeze state.
Well, so there's interesting conversations about freeze. So on the hypoactivated side, we'll oftentimes talk about sort of a collapse or a submit response. And freeze is one of those interesting ones where some people will place it in the hyperactivation state. Like they did an interview with the after the Boston Marathon bombing with the man whose his car was carjacked, I guess, but he was in it. So they drove around with him in it. And they talked about sort of he was in this hyperactivated freeze state where he was sort of anticipating possible movements. And so freeze can be both sort of a activated freeze where our body is primed to either fight or flee, or it can be sort of a shutdown freeze where there's a reduction in activation in the nervous system. It's really more akin to that collapse state. So it's interesting when you watch nature videos, you can actually see sometimes where prey animals who are about to be overtaken by a predator, their bodies will actually go into a collapse state right before they're about to be overtaken. And the body at that point actually floods with endogenous opioids, so endorphins, to numb the physical system to the incoming experience of pain. And so our bodies are sort of wired for survival, and in the sort of possible threat to that survival, they're also wired to reduce our experience of pain. And so we can start, so that freeze that's more of that shutdown state will actually, there's a numbness that will come with that. And yet there's also sort of a reduction in blood flow. So the blood actually goes back into the core of the body at that point.
That's so interesting. It seems like far too little attention is paid to this step of increasing self-regulation and just acknowledging that people really need work there. It sounds like from what you described, some of that work that you do is the individual doing it on their own as a practice, and some of it is in relation to you in a therapy session.
Yeah, I would say both. Hopefully, both in relationship to me in the therapy session, and also finding outside people as well. I mean, I think that's sometimes one of the most difficult things for people who are coming out of addiction is they've disrupted a lot of relationships in their world, and so there's oftentimes a real absence of people who are available to sort of be that soothing or regulating other. But ideally, the hope is that it can be increased beyond just the therapy room as well. But oftentimes with the therapist or a counselor, that's one of the first times they begin to get somebody who's willing to sit across from them and say, notice what's happening right now, and let's work together to help you stay more present and calm, and begin to sort of shift away from that dependence on a substance to do that for them. And so there's an interesting book that was written several years ago called Addiction as an Attachment Disorder, and sort of looking at sort of or sort of emotion regulation, self-soothing. Those are largely sort of in caregiving dynamics. Those are largely the product of secure attachment relationships. And in the absence of those secure attachment relationships, we turn to whatever we can on an external basis to continue to get those needs met. And substances are predictable. They give sort of a similar sort of you get a similar sort of effect out of them when you use them. And for a lot of people, they're more readily available than sort of effectively carrying relationships. And so it makes sense that they have a really powerful hold on people's lives. Mm-hmm. And so my hope is that sort of if we begin to work together, there's a greater increase in sort of their ability to do some of that regulating while in relationship in the therapy work, and then building that capacity to do some of that work on their own. And for me, I think as people really begin to demonstrate that they can more effectively do that work both in session and out of session on their own, it begins to sort of provide the evidence that they're ready to do further trauma processing work, to actually go back to the memory and do some more past focused work. And so sort of that phase one trauma work is often, it's really present focused work. It's helping people to be more effectively here and now. And then phase two work is really more sort of helping people to revisit the way it's sometimes talked about, is revisit the there and then from a more resourced place.
So you said it was a triphasic model, and you've mentioned two of the phases, and I'd like to hear more about the second one. But what are the three?
Sure. So the first phase is really about stabilization and skill building. Phase two is really about trauma processing. So it's actually revisiting the past. And then phase three is really about integration. And so it's taking in the sort of the new relationship you have with those memories, it's taking in the new ways that you have to see yourself, and then sort of determining from there how you want to build your life forward. And so, so Dan Siegel always sort of comes to mind for me when I think about integration, because he talks a lot about integration as sort of the connection between differentiated parts. And so really the goal is to help people have as coherent and connected of a world as possible. So connected within themselves, connected between themselves and others. And I think more often than not, there's some level of connection between themselves and sort of the world, or a higher being, a higher power, or something beyond themselves as well. That's sort of like Dan Siegel talking about, like the interconnectedness of all beings is sort of a form of integration, and sort of tapping into sort of that sense that we're all connected. We can't ever be sort of separated and in a vacuum. Like our actions impact other people, and their actions impact us, and so on. So
even if we're isolating, as people often do when using, that's still impacting other people and stuff.
Yeah, absolutely.
So so can we talk more about the phase two? You started to explain how you do, and you're saying that the trauma needs to be re-experienced in a certain way.
Yeah. So so the models that I've been training in to all have some aspect of, I think, sort of a multi-component process of doing exposure work. So it's, I think within EMDR, you're doing exposure, but you're also pairing it with something that helps you to stay present. So usually that's taking some form of bilateral stimulation, which in its original creation was through eye movement, and through sort of the further iterations oftentimes includes things like can be tapping on alternate sides of the body, or holding onto buzzers that alternate vibrating in the hands, or audio tones, which is theorized to increase sort of processing across both hemispheres of the brain, because trauma is typically held primarily in the right hemisphere. And so sort of increasing activation on both sides of the brain while remembering something difficult from the past, and sort of all the associated sensations and beliefs and feelings that come with that. And I've also done training in sensory motor psychotherapy, which is a model that's body-centered. And it's really trying to identify the ways in which trauma is held in the body. And oftentimes the ways in which it's held is through sort of the incomplete defensive action. So like I said, our bodies are wired for survival. And so when we encounter something that's threatening, our bodies activate to either help us move towards that thing or away from that thing. Or if we can't if it appears that we're not going to survive it, to shut down and hope that that thing leaves us alone. And when none of those things work, we're oftentimes left with that activation within our nervous system that perpetually gets re-triggered on an ongoing basis, and leaves people feeling really stuck in this looping sort of experience of trauma. And so, so sensory motor psychotherapy is an approach that's specifically looking at how do we help the body discharge that stored energy, and essentially complete that defensive action, so that the body can come back to a state of rest and be more regulated again. And so those are the models I tend to use the most. But I think any of those models, in terms of that second phase work, they're really based on helping the person to go back while being more resourced. And so trauma is often talked about as sort of overwhelming a person's resources and capability to respond and effectively integrate what's happening to them. And so that's why that phase one work is so vital, because and why I think so many people stay stuck in a cycle of addiction, because they're never increasing their resources. They're not more capable of integrating things because they're in the case of addiction, they've found a very specific way of sort of resourcing themselves, so to speak, but it's a really destructive way. It actually reduces their ability to be present. It disrupts their ability to engage the world and be in relationships. And so with that, we're trying to sort of steadily increase the person's confidence in themselves and their sort of ability to sort of remember while not being overwhelmed. And when they're able to do that, oftentimes they're able to more effectively sort of shift the ways in which that memory is stored. And so Dan Siegel again talks a lot about the ways in which anytime we retrieve memory, we create the possibility of modifying that memory. And so he says memory retrieval is memory modification. And so when we help people to remember more effectively, we also create the capacity that they can modify that memory and their relationship to it and store it, so it's actually more effectively stored as memory and doesn't continue to show up in sensations and emotions in the way that trauma oftentimes does.
And you mentioned another method, brain spotting. Can you explain a little what that is?
Sure. So brain spotting was created by David Grand, who is an EMDR practitioner and teacher, who was also trained in somatic experiencing, which is another body-centered approach. And so in his work, he would do a lot of performance-based work with athletes, and at least as the story goes, in his initial sort of discovery of what later became known as brain spotting, he was doing EMDR using eye movements, and found that people's gaze would consistently stop or stall in a particular spot during the eye movement. And so at one point he decided to hold the person's gaze at that spot where their eyes kept stopping. And a whole flood of sort of traumatic material began to process through, and the person was moving through things that they had previously worked through, but doing so at a deeper level that was actually allowing them to sort of feel a greater sense of resolution. And so he began to develop a model that's really it's activation focused. So it's really, you identify something, and that could be a thought, a belief, a memory, an experience that feels activating in the nervous system or the body, and then you're pairing that place of activation with a particular focal point or gaze point. They call it a brain spot. So it's, you use a pointer and you actually use that to help somebody locate a particular spot within the visual field at which they feel that sort of sense of activation at its most intense. And then you through the pointer, you help them to maintain their gaze there and allow whatever begins to unfold, with the idea that sort of where we look is directly correlated with sort of feelings, sensations, and memories. And so you're helping somebody sort of through the visual stream to actually begin to connect into that memory system and begin to process through it. And I think there's also a way in which that pointer serves to also serve as sort of a present moment reminder or sort of anchor as well. So it keeps somebody sort of co-located, so they're remembering while at the same time sort of having something that holds them in the present moment with the therapist across from them. And so I found that to actually be a really profound way to help people move through traumatic material as well, especially if people are really in that activation state. I think people can really sort of, people I think are really frequently surprised at how easy it is for them to find sort of that particular brain spot or that gaze point. And then a whole bunch of things begin to process through, and people can experience pretty rapid shifts in relationship to those memories and things like that.
That's really interesting. interesting. Yeah, I've done EMDR for a long time, and I've noticed, yeah, that getting stuck phenomenon.
Yeah. Yeah, and the EMDR, they develop different strategies for working with that. So you either change the direction of your passes or things like that. And here he tried something totally different and developed a whole model
Oh,
of sort of therapy out of that. And so so I usually try to, as people get to that place where they're more ready to begin working on trauma, I usually try to sort of hopefully explain things well enough that then people can make a choice about what they feel most drawn to in terms of
mhm.
working through the traumatic material.
So do you use TRE at all? The shaking? You know
You
about
know,
that?
I'm aware of it and I'm super intrigued by it, but I haven't done the training in it. It was supposed to come here to Minnesota last year and got canceled, and so I'm hoping at some point to be able to do the training because what I've seen of it, and I bought the books and I want to buy the DVD, but it looks fascinating. Actually, it looks like there's some crossover to what sometimes comes up in sensory motor, or in like somatic experiencing as another body-centered approach. But here, obviously, it's very targeted at specific places within the body that's sort of energy gets held and sort of allowing it to discharge through. So, um,
Well, and what's really interesting about it, there's no talking. And so, people are obviously working through trauma or processing trauma in the body
yeah,
without words.
yeah, yeah. I think the more that you can help people to begin to get in their bodies, um, and sort of recognize that words aren't always going to be the sort of the means by which we help people recover. I think the better. And so I think there's a lot of shifts happening in the trauma field around incorporating some form of body-centered work, whether that's yoga or TRE or some of the body-centered talk therapies like sensory motor or somatic experiencing.
Mhm.
So hopefully that continues to create new avenues of healing for people.
So do you do any group processing? Or is it mostly individual?
So, so I'm in a new position currently where I came into this organization about 3 months ago. And prior to that, I had been doing group work for the last 5 years in a co-occurring eating disorders and addiction program. Um, and so I was facilitating several process groups there. They were more sort of emotional and interpersonal focus. So we weren't doing a lot of like trauma processing groups, but really focusing in on sort of the interpersonal dynamics and sort of attachment histories that's contributed to the maintaining of addiction and eating disorders for clients. And so my hope is that we're developing some intensive outpatient programming here and some sort of single groups that will be ongoing for people around addiction and trauma and eating disorders. But currently I'm not doing anything, but I love doing group work. It seems like such a powerful, so I've always experienced as a really powerful way to help people sort of
Mhm.
tap into their own experience while being witnessed by other people, and begin that process of healing in safe spaces, which most of them didn't have at the time that the original sort of woundings happened.
Mhm. So, do you want to say you started to talk about phase 3, and you said a little bit, but do you want to say more about what phase 3 is?
Sure. So, so phase 3 work is really about it's the integration phase, but it's really about sort of taking everything that is sort of beginning to emerge in the process of healing, and beginning to shift towards a greater sense of choice and agency in life, and figuring out the life that they want to live when they're no longer just sort of stuck in a pattern of reacting to life. Um, so I talk a lot with my clients about sort of like procedural memory or procedural learning. So like the things that we learn to do and then don't have to think about doing them as we go because it just becomes sort of a procedure for us. And I think a lot of addiction and eating disorders have a real procedural element to them where sort of we learn that when we feel this, we do this, or when we experience this trigger, we use this substance or we use this symptom. And so I think a big part of that means that people are locked into oftentimes almost autopilot type forms of behavior because so much of procedural learning is automatized. We don't even have to think about it. Our brain associates those things so tightly. And so the hope, I think, is that by the time people reach that phase 3, that they're at a place of being able to make choices for themselves now. They're not just living out of a place of sort of reactivity and patterned behavior, but actually feeling like they can choose new things. And so there's really interesting research that comes out of the obsessive compulsive disorder field. Jeffrey Schwartz is a researcher. I think it's in Southern California, but he's actually done brain studies looking at obsessive compulsive disorder. And I see a lot of overlap with that and addiction and eating disorders. In that sort of the way the brain is supposed to work is we have a thought, and then so the brain fires around the thought, and then the brain has a separate firing for the action. And so we sort of have a thought, and then we have this sort of urge to do something. And so what they found out with obsessive compulsive disorder is those two firings within the brain become almost simultaneous. And so the separation between sort of registering an experience and the urge to do something is happening almost simultaneously. And so a lot of what his research focuses on is that it's not just the absence of something that creates neuroplastic change within the brain. It's the presence of something else. And so for a lot of clients, particularly those who have addiction, they come in and we tell them, okay, you need to stop doing this thing. And then they think things will somehow get better and their brain will change and they'll experience less of a sort of a reactive pull back towards that substance. And most people don't find that to be the case. They stop using it, and then if they don't have something else that's sort of pulling their attention and their energy, when they get triggered again, their brain automatically fires right back to that thing that they used to always do. And so for a lot of my clients, part of the early work is oftentimes beginning to build up options. And so increasing the possibility of doing something else. And so rather than the brain sort of 100% firing and saying, you feel this, so do this. Now it fires and says, okay, you feel this, and there's a 20% chance that you'll do one of these 5 things, one of which may be using the substance that you've always used. And so I think of that as sort of you're increasing agency at the beginning and then the end result is hopefully sort of really empowering people to sort of now use that agency to sort of create the life that they want to live and have the relationships that they want to have and step away from the situations that don't fit for them any longer. And so I think there's oftentimes a lot of sort of spiritual development that comes through the process of healing. And phase 3, I think, is really that process of developing coherence of self and developing that greater sense of connectivity across relationships and sort of what do they want to do with their life now. And what's always really fascinating to me is watching the ways in which people who begin to heal from trauma very frequently as they move along the healing process find ways that they want to give back, and whether that's serving other people who have been impacted by trauma, or certainly this is really normative in the sort of the substance use disorder field, where a lot of people in recovery choose to want to sort of serve other people who are trying to reclaim their lives from addiction. But I think it's very true of trauma as well, and the ways in which people will sort of dedicate their lives to doing something to impact the lives of others. And I think that's such a sort of evidence of that spiritual shift that's really becoming more integrated in that sort of third phase of trauma work.
Yeah, that's beautiful. So I know that you work in a hospital setting. You do inpatient or intensive outpatient?
Yep. We have an inpatient unit, but I work in the outpatient side, and we're developing an IOP, and we have a mind-body focused PHP that's been in place for several years. And so I felt really fortunate to step into the outpatient clinic opened about 6 months ago or 7 months ago. But it's always had sort of this legacy of being really mind-body focused. So helping people to sort of move back into their bodies and into their sort of present moment experience in a really intentional way. And so, so that's sort of the overall sort of focus within the clinic is on that sort of approach to working with clients.
So just for our listeners that might not know the abbreviations, IOP is intensive outpatient and PHP is partial hospitalization. And so I'm
Yes.
wondering, you have this great triphasic model. Do you have time to do that with all the insurance restrictions, and how long do these different phases take, and do you feel like you have time to bring people through them?
So a lot of it ends up being in individual therapy. And so I see, I would say sort of our use of things like IOP and PHP are oftentimes more part of that first phase of work and helping people begin to develop skills. And I think that's partly what I love about the mind body approach is it's really oriented towards helping people to be more present and have the skills to better regulate and stay present when difficult emotions or difficult thought content comes up. And so I would say, no, not always is the time available to do some of that work, because I think there's a lot of clients who would really benefit from a more extended amount of time in whatever setting. I think for some clients, that phase one work is almost necessarily going to happen in a inpatient setting or a residential setting where they have actually the environmental and contextual safety that allows them to begin to do some of this work, to begin to build skills and increase that window of tolerance to stay more present for their experience. And then that phase two work is oftentimes that sort of halting process of you begin to do some of that difficult working through the past memories and past content, and relapse will frequently happen. And so I have clients who they begin to do some of that phase one work, and it's sort of very halting or sort of stop start in a way. Like I think especially if you're doing an outpatient setting in any form, there's a lot of clients who I feel like I've learned to develop a much greater tolerance when I was initially working in an inpatient substance use disorder treatment setting. Because it always felt like relapse was just instantly sort of a reason that people at discharge and then they go out and then come back once they were sober again. But in an outpatient setting, it's a lot of working with people, trying to help them maintain sufficient level of stability, reducing the length of their relapses, recognizing the ways in which trauma triggers will frequently propel them back into using again, and developing a really coherent set of strategies to begin to sort of buffer against that as much as possible. And I have some clients who have 30 or more inpatient or residential treatment stays for substance use. And I think more often than not, it's because nobody addressed their trauma at any point along the way. And finally they get to a place and somebody says, what happened in the past that contributed to you beginning to struggle in these ways? And they start to lay out these histories of early childhood abuse or significant neglect and later violence that they experience. And so those are frequently the clients who oftentimes they run out of any sort of higher level of care benefits. And so you're working with them almost exclusively on an outpatient, sometimes even individual therapy only basis. And so frequently then, as much as I can, I'm trying to build in as much of a scaffold as possible to support them in beginning to establish adequate sobriety to sort of demonstrate that they have some skills and strategies to manage that relapse cycle. But it's really hard. And I think with those clients, individual therapy rarely feels like it's enough. And so building in IOP or even things like DBT, dialectical behavior therapy groups, or I have several referrals in the community for trauma-informed body work or trauma-focused neurofeedback. And neurofeedback is a sort of a computer-assisted form of biofeedback that allows people to effectively sort of get real-time computer feedback about how regulated their nervous system is. And then with usually a therapist present, somebody is there helping them to sort of downregulate or upregulate their nervous system, and the computer is showing them how well they're doing it. And so I've had a number of clients who struggled significantly with relapse begin to do neurofeedback, and that shifted their ability to self-regulate so significantly that it was no longer sort of just the individual therapy appointment in which they could stay present and regulated. Now they are doing it on their own as well. And so I think as sort of time goes on, and as sort of different levels of care are or are not available to people, you have to really find ways to sort of augment what they might otherwise get if they had sort of longer residential care available to them. So,
well, and it's amazing how much insurance money is wasted on multiple treatments if they had just allowed the time to treat the trauma.
Yes,
they had a much better outcome.
Yeah, I saw it when I was in primary care treatment. I saw this all the time, where people would come in and they just start identifying these struggles that I had sort of been with them for years. And I think for me, like when I started Minnesota Trauma Project, which is an organization that train other therapists and providers around trauma, it really was born out of this frustration of watching clients come in and they'd say, I've seen 5 therapists or 10 therapists, and I've been to 15 treatments now, and nobody's ever said, what about this trauma that happened in your past? And then they get discharged after 14 days because their insurance would say, oh, you've had enough and you've done so many treatments, you should have gotten it by now. I have one client who left because insurance said 14 days was enough, and she intentionally went out and relapsed on a drug that wasn't even her drug of choice, so she could justify getting sent back for another 7 days just to keep doing some further trauma stabilization work. And so it's heartbreaking, I think, to see the ways in which clients are suffering for years to decades without anybody ever saying, like, there's actually help for those struggles. There's sort of a way to heal that pain or those wounds. And so, yeah.
So can you talk a little about the Minnesota Trauma Association and what work you're doing with that?
Sure. So Minnesota Trauma Project was sort of born out of like I said, out of this frustration of seeing the vast under preparation that most of us come into the field with around trauma. And so far we've been putting on workshops locally in Minnesota that we sort of, because we cut out any sort of middleman, we can put on the workshops at a much lower price point and make them really available to people. Because the reality is, more often than not, the people who are working with the most traumatized clients are frequently working in the lowest income settings in terms of the populations, as well as frequently the lowest paying settings. And so there are resources to go to trainings and get sort of advanced information around how to work with trauma and dissociation and trauma and addiction and things like that can be limited. And so we've been putting on about 4 to 5 workshops a year so far over this is our 3rd year of doing it. And typically 100 or more sort of providers are attending those workshops. And then trying to find other ways, like go through our website and through some community awareness events. So part of what we've begun to discover is there's a lot of lack of awareness at the community level of the ways in which trauma is so significantly a part of the picture for a lot of people. And we know that, as far back as the early 90s, they began to map out the role of what they came to call adverse childhood experiences on later development of addiction and eating disorders and obesity and an array of medical concerns. And yet we don't do a lot of training coming out of our graduate programs to come out and say, oh yeah, I know what you're dealing with. It's trauma, and let's work together to help you heal and recover your life. And so we now have sort of a multi-pronged approach to trying to educate the community around the issues that they likely are struggling with but don't even know that it's trauma, and then educate the providers who are frequently encountering clients in the therapy or consulting room or treatment setting. And if they don't have a lens for it, they're not looking for trauma with their clients, and then they're not providing the treatment that those clients need. So that typically then leaves people stuck in a lot longer cycles of use and relapse and everything else.
Mm-hmm. So how do you define recovery? If your treatment works really well, what's recovery look like to you?
Yeah, so I would say it's really about that integration of sort of across domains. And so it's that integration within the self. And so the ability to be present to thoughts and feelings and emotions so that the normal pattern of avoidance that is sort of basic human nature and it's sort of, I mean, we're wired to avoid discomfort. And that discomfort can be something that's outside of us as well as something that's inside of us if we've learned that our feelings or our sensations or emotions or memories are overwhelming. So I would say it's sort of integrative at that level. And sort of the ability to sort of locate ourselves in time and sort of be fully present and intentional, and really be able to engage in relationships that are sort of dual and mutual, where sort of we give and we receive. And there's that ability to sort of have a more sort of coherent sense of integration where we begin to break out of those old patterns of whether it's feeling like we need to be, I mean, the terms that frequently get put to things like codependent or dependent, or sort of pathologically independent, for lack of better words. I mean, I think the ways in which we learn to be so self-reliant that we can't engage people in a way that allows us to receive from them. I think that's equally an unhealthy place. And so it's really sort of being able to engage in a fully aware and conscious way at sort of the individual, the interpersonal, and sort of the that spiritual level as well, of being able to sort of create meaning and purpose and pursue lives and actions and behaviors that match up with that meaning and purpose.
Beautiful.
So I guess sort of one other thing I would say is just sort of honing back into the idea that sort of as humans we're wired to be relational, and I think trauma ultimately sort of impairs our ability to be in relationship with ourselves, which ultimately impairs our ability to be in relationship with others. And I think so then people oftentimes will develop these relationships with external things, and whether that's substances or symptoms, for like eating disorder symptoms or behaviors like gambling or things like that, that provide some sort of temporary charge within the brain and in the body, but ultimately takes us further away from the thing that's actually sort of most healing, which is entering back into some form of relationship with ourselves and entering into relationship with other people. And so I think we know that. I think we see that within the 12-step community, that there's this significant emphasis on healing within that, on that level. And I think when I think one of the beautiful things is when you can really begin to see people begin to shift sort of those patterns of how they engage the world and interact relationally, so that they can create more meaningful engagement with sort of the entirety of experience. And so it's this beautiful thing of sort of trauma becomes really narrowing and restricting to people, and sort of recovery is hopefully generative and expansive. It allows us to sort of engage life in a more sort of abundant and fulfilling manner. Like I always think about the ways in which I've watched clients who sort of miss out on beauty and sort of awe and wonder of the things around them. And as they begin to sort of heal and recover, they begin to take notice of all these little sort of small things that sort of bring joy and happiness and satisfaction to their world. And so I think sort of increasing that capacity for wonder and beauty is a really amazing thing that emerges out of trauma recovery, and I think oftentimes out of substance use recovery as well. So there's another thought.
Yeah, I like that. So I think people are lucky to be in your treatment center. How do people find you?
So my so the so Minnesota Trauma Project is just minnesotatraumaproject.org.
Okay.
That's not a treatment program as much as a sort of advocacy and education organization. And then the hospital that I work at is North Memorial Hospital. And then we have a mental health and addiction clinic here. And that's primarily an outpatient clinic that, like we talked about, has both the intensive outpatient programming as well as the partial hospitalization programming. They all have some aspect of trauma sort of focus lens to them. And we're in the process of developing a trauma focused intensive outpatient program that will really sort of incorporate things like eating disorders and addictions with a real trauma focused lens. So trying to move beyond just doing trauma informed work, but really having trauma be the primary focus of the work that we're doing. And sort of healing the various ways in which people have tried to cope along the way. So
Well, thank you so much, Ryan. This has been really
absolutely
interesting and encouraging. It's kind of with every interview that we're doing, we're gaining hope that we can. There's better treatments out there with better recovery rates, and you're certainly an example of that. So, thank you so much.
Yeah, absolutely. It's a pleasure. It's always exciting to increase greater awareness around trauma, and I think especially in the substance use field. I mean, we know there's actually research out there that shows that focusing on trauma increases both treatment retention as well as treatment outcomes. And if we're not doing that, we're leaving people stuck in a cycle that could more easily be broken out of. So yeah, I'm appreciative of the work that you guys are doing to broaden the lens through which we look at this work.
Go to kilobycenter.com, Radical Recovery Summit, to see the full schedule of speakers and to register to watch these free online September 23rd and 24th in the Radical Recovery Summit 2017.